Hello again, everybody. Welcome to No Bones About It. My name is Beau, joined today by Dr. Abram Elsenraat, I guess one of the newest doctors here at Columbia Orthopaedic Group. He is specializing in pain management, and we'll talk about his story to get here because, Doc, you've been around Columbia for a long time, more than a decade.
Yeah. I guess about 12 years now?
Yeah.
And I was an anesthesiologist at Boone. My primary specialty was cardiac at the time, and decided to explore other options, which I'm calling my kind of midlife crisis.
But it's led you here, and you did all that work at Boone, so you got to know the people from COG. You worked cases, I'm sure, with some of those physicians, and then you said, hey, I'm going into pain management. What made you make that transition?
Oh, that's a really interesting question and requires a long answer.
Long answer.
So I started my career after medical school as a Navy flight surgeon. I was stationed with the Marines, and built a good bond and rapport with a lot of Marines. The squadron that I was in a few different squadrons, but the first one was HMLA 167. There's about 450 Marines that were in that squadron, and I was basically their general practitioner that also flew with them. So I took care of everything, that needed to be taken care of for them, kind of from top to bottom, and then would, obviously refer out to specialty care from there. When I left the Navy and started my anesthesia residency, I didn't think that I was really going to miss that kind of patient care, that longitudinal care that went along with it. And initially, I wouldn't say that I did. I mean, I was having so much fun, doing anesthesia and everything that it entails. But over the years, I kind of started to miss that follow-up, that longitudinal care, and started exploring this again. And I say again because I considered doing this out of residency. Mm-hmm. It was a different time frame back then. The market was a lot different. We wanted to get back to Missouri, and it felt like at that time that the cardiac pathway was the best way to kind of get us back here. And I really enjoyed it as well, because I was really torn between cardiac and pain at the time. And then when there were a few jobs for cardiac back here in the state, that kind of maybe pushed us in that direction. But it was a very difficult decision even then to make that determination.
Yeah, I can believe that. But we're glad you're here. I don't want to gloss over your military stuff because it's fascinating. I mean, you were in Iraq twice.
Yep. Twice with HMLA 167. We're at the Al Asad Air Base. And that was, I'd have to remember back, but it was like in 2004 and 2005. And I may be a little bit off on those times. I'm pretty sure that's the ballpark when we were there.
That has to be Iraqi freedom, right?
It was.
Yeah.
Yep.
I mean, serving your country and helping the Marine, I mean, that's incredible. I mean, you must have unbelievable memories and stories from that.
There's quite a few stories. Yeah, there's quite a few stories, and quite a few memories. It was a really extraordinary time. We were on a very operationally heavy deployment at that point in time. We were on a rotation where we were 7 months gone, 5 months home. And in those 5 months that you were home, you'd spend time working up to leave again. Mm-hmm. So you'd spend time out in Yuma, Arizona, when you were home, getting ready to leave again. So when you were home.
Yeah.
So really, in that time, it was really a lot, that you had to do. And I eventually, with that squadron, switched into a different one, which was HMH 461, which was a heavy squadron. And that looked at it from a completely different aspect. It wasn't the same. They still had an operational deployment. Tempo was pretty high. However, I never did deploy with them. There was an opportunity, which is a funny story, where I was supposed to go to Djibouti, which is the Horn of Africa with them. And my wife loves and hates the story at the same time. But we had gotten married at the time. And we deliberately got married on a Friday in a civil ceremony, hoping to do our wedding the following year on a Saturday, so the date would stay the same.
Yep.
Well, the needs of the Navy dictated something different. And when I was with that squadron, we were given deployment orders to go to the Horn of Africa. It just so happened that it was going to be during the time that my wife had planned the wedding. So, the CO at the time told me, I said, okay, well, that's, needs the Navy. We got to do it. This is what the operational requirement is. So I went home and told my wife, I said, sweetheart, I know we had this wedding planned, but we're going to have to cancel it. And we'll have to, push it out another year if we want to keep the date the same. And she was great. She's like, okay, I get it. I know this is part of it.
Yeah.
So thankfully she was able to talk to all the vendors and they understood. So they just pushed it a year, didn't lose deposits or anything like that. All was fine.
That's good.
All was fine. However, 2 months later in that ballpark, the CO came and said, hey, our detachment's changing. We're not sending the same amount of, people that we had there. So you don't need to deploy.
Oh, no.
And I said, sir, I do need to deploy. I got to deploy. My wife just canceled everything. You got to tell her that I'm not deploying now. Anyway, long story short, it all worked out. I didn't deploy with them. We did push our wedding to the next year, and we just have 2 different days, not
Yes.
Yeah.
That's fascinating. So you go through all of that, then you come back and you're at, if I'm not mistaken, Penn State, Ohio State, and then you end up in St. Louis. Is that right?
Correct.
Okay.
Yeah. So, again, it was a different market back then. There was a couple jobs in the state. Our whole goal was to kind of get back to Missouri. I really wanted to either be in Columbia or St. Louis, which is close to my hometown of Herman.
Yeah.
So we could get back and forth pretty easy. We still had young kids at the time. And there were really no jobs here. I did find one that was in St. Louis. And I say no, there were no jobs here. There was one at Mizzou. It didn't fit what I was looking for. So my really only option was at St. Louis. So we went there and I practiced there for 2 years before then coming to Columbia to help them start up their TAVR program.
And as you come to Columbia, you go to Boone and you serve as many different roles there. So it tells me that you're really active and not only with your patients, but you want to make sure that everybody's healthcare and healthcare experience is a good one.
Yeah, I did have a lot of roles there, and it was very time consuming, which is another thing that kind of maybe helped push me in this direction. Getting pulled in more and more to administrative stuff. I was even missing more of the patient care that I wanted. Not that I was missing it because I was still incredibly active with patient care. It's just that my attention was getting diverted in different directions as well. So I knew that I wanted to get back into this and, that itch that needed to be scratched kind of thing. And actually it was Dr. Newton, who is here, that I talked to him, and he's got a very similar pathway. He did it after being an anesthesiologist for a while. And he graciously agreed to talk with me. And when I heard his pathway, we were essentially the same age, same practice, that he did it. I said, if he did it, why can't I?
Yeah, good for you. And I'm sure that when you made that leap, from then till now, pain management has changed a lot, hasn't it?
Yeah, so when I was training, there was a lot of procedures that we currently do now that weren't around then.
Yeah.
And that was one of the other things that helped push me to this direction. I was seeing the new stuff that was coming through in interventional pain, and I really thought it was interesting. I thought that, this is some drastic change that's happening in the interventional pain space. I'd like to do that.
Yeah, good for you. And let's talk about some of those changes and some of the things you do. If somebody's watching this that wants to be a patient, just give them a little bit of a rundown of what you do.
So, obviously with everything that we do in the interventional pain, we want to start with the most conservative stuff and increase. So, we offer all kinds of procedures, but the basic thing that we have to start with is their functional capacity, their the strength and core and conditioning, along with physical therapy and medication management. If those don't work, or they would require additional services, we can offer those. And then it would be stuff like epidural steroid injections, medial branch blocks to help with back pain that doesn't go to their legs, SI joint injections, and we can do those in the neck as well to help with arm pain as well. There's other procedures that get more and more advanced, like spinal cord stimulators. There's basivertebral nerve ablations. There's multifidus stimulators that you can put in as well. There's peripheral nerve stimulators. And again, this is kind of as you climb up, you get more and more invasive along the way. So a lot of these things that I just mentioned here at the end, we didn't have available when I was training initially. And that's the thing that's really fascinating now is how the evolution of pain management is happening to get more kind of minimally invasive with these procedures to really help patients that are in chronic pain.
And we see more and more patients who are in chronic pain. I mean, they walk into the ouch clinic, they call up and say, I'm in pain, I can't take it anymore. It seems like maybe because people have been a little bit more active, they have more pain. Am I right in that? Or is it just...
I don't know. I did read a stat the other day that said at some point in time, there's over 100 million Americans that have chronic pain. So if you think we're, a little over 300 million, that's a third of the population at some point in time has experienced chronic pain. So that's no small number by any stretch.
When you meet a patient, when they come into you, I'm sure the first thing is, tell me what it hurts, tell me what it feels like. Because as you said, the first thing you want to do is conservative and say, hey, let's see if we can manage it this way, right?
Yeah, the first thing I want to do is understand, kind of where they're coming from, what their process has been to get to me. I think that's a huge, thing to look at because there's people that have kind of navigated the medical system and never really gotten explanations that they want or need or had spent the time with them. So I like to sit down and just say, hey, where have you been? What have you been through? And then what options do we have in the future? And I kind of treat it in a stepwise process like we laid out. It's the therapy, medications, and then intervention. And that's the kind of pathway we like to go. Now, they don't have to, they can, occur parallel to each other. But that's kind of how I look at pain when someone comes in. Here's our options and how do we explore them from there.
Let's talk about the pain team that's growing here. I mean, Dr. Noble's joined, you've joined, Dr. Newton, as you mentioned, Dr. Hansen is here. It's really growing into a strong team. If you have pain problems and need pain management, this is the place to come, isn't it?
Yeah, we at this point here now have, to my best recollection, the largest pain group
I think that's right.
in the area. I think you'd have to, you definitely have to either go to Kansas City or St. Louis to find a bigger group than what we are to offer the comprehensive pain management process that we have here.
What do you think the future is of pain management? Who knows?
Who knows? I think things are, continually changing. I think there's a lot of new modalities that are coming out that are yet to be proven. Which is good and bad because, we're going to miss the mark sometime. But there's going to be a lot of these are going to be game changers for patients that have never had any options before.
Well, you mentioned you're married. Let's talk about a few personal things. Your kids and all that. How happy they are to be in Columbia, I'm sure, and staying in Columbia. And even though Dad's going through a midlife crisis, things are doing good.
Yeah, that was one of the things when we told the kids that we were going to plan on that Dad was going to do some more training. The first thing that we wanted them to know was we were not going to disrupt their life. I have kids that are in different schools here in Tolton and at Our Lady of Lourdes. And to move them for a year, we just weren't going to do. So we wanted to lay that down first. And then after that was resolved, like, go do whatever. You're never home anyway.
Absolutely. Yeah. Well, you're not home, so we'll be just fine.
Yeah.
As long as they're not disrupting my life. Well, we're happy to have you here for sure. If you need an appointment, 876-8141. That's the appointment line here. And this is Dr. Abram Elsenraat, and I want to thank you for being on here.
Thanks for having me.
You betcha. We'll see you next time on No Bones About It.